Thank you for once again for having me here, and thanks to the chairman and the other speakers for changing the schedule. I also have another talk in the other room, so I kindly ask to be moved upwards. So I think many of you are nowadays becoming more and more familiar with this concept of driving pressure, which is something we've literally have been dealing with since, I would say, the very beginning of mechanical ventilation. One of the criticisms that is moved to those who introduced the driving pressure is that, well, there's nothing new under the sun. We knew this since many, many years. The point is, yes, of course, we did, but perhaps we did not pay that much attention to driving pressure and to its potential role in ARDS, and I would say in setting mechanical ventilation more in general. Because what is the problem for ARDS patients is sometimes also problems with patients who do not have ARDS but still are challenging to ventilate. Okay, my conflicts of interest are not related to the present talk. So I think this is a very good point to start from. The concept of the baby lung that was introduced by Gattinoni and Pesenti back in the 80s, and this is an interesting paper which I would recommend you to read if you haven't done so. About 10 years ago they published this paper which reappraised this concept and put it in the framework of the knowledge that had been developed in the meantime. So basically the concept of the baby lung is the fact that ARDS lung is not just stiff by itself, but it is stiff because it is small, and the smaller the lung is, the stiffer it is. And so we have learned also, starting from the 80s, that mechanical ventilation can promote injury of the lungs. It is an invaluable tool to save our patient's life, but of course, as every drug and as every procedure, it has downsides. And the downside of mechanical ventilation is the promotion of inflammation and injury to the lungs by means of two main mechanisms. One being the distension of what is normally aerated, the lung that is open and has to carry the burden of the ventilation for the entire lung, so our baby is working as an adult. Child should not be working. And here we have a baby who is working as an adult. And also we have the issue of alveolar units opening and closing at every breathing cycle, known as atelectroma. Now in the next part of the presentation I would focus on the first type of injury because it's really what driving pressure can assist us in avoiding. We all know that the use of low tidal volumes has shown to have a protective effect on ARDS survival. This was the seminal study published by the ARDS network. 6 ml per kilo is different from 12 ml per kilo. So the current recommendation is to set the tidal volume over ideal body weight. And also, what this study has shown is that even if your plateau pressure is low, the use of low tidal volumes is protective. So these you see are quartiles of plateau pressure. On the left-hand side were patients with a low plateau pressure, where you would not really be worried much about the risk of mechanical ventilation. But even in those patients, as you see in the black bar, the use of high tidal volume caused an increased mortality as opposed to a lower tidal volume. if we take a look of the what is the real life results taken from the LungSafe, we have that normally we tend to ventilate patients with a tidal volume which is slightly higher than the 6 ml per kilo, is about 8 ml per kilo, and we tend to use lower respiratory rate than what we would expect. So now I would like to shift gears a little bit and ask you, what should we scale tidal volume on? And what we currently do is scaling tidal volume, and if we do it, we scale tidal volume on patients' ideal body weight. What's the problem? The problem is that we do not ventilate the entire patient. We just ventilate his or her lungs. So this principle would work under the assumption that the size of the lungs is correlated with the ideal body weight. And this is the case, almost the case, for healthy subjects. If I take me, you, the size of our lungs are related to our ideal body weight. But the problem is that in ARDS, the size of the baby lung is not related to the body weight. The size of the baby lung depends mainly from the extent of the disease. So what we should really care for is the ratio of tidal volume to end expiratory lung volume. We want to scale the tidal volume to the size of the baby lung, so that the baby lung carries a weight that it is able to carry. Why do I introduce this concept? I will show you in a minute. These are some experimental data that show that indeed the ratio of tidal volume to functional residual capacity, or end expiratory lung volume, which is functional residual capacity in the presence of PEEP, but let's say end expiratory lung volume. The higher is this ratio that some like to call strain. I prefer to call it tidal volume over end expiratory lung volume. The higher is this ratio, the greater the degree of injury. You see here animals. Animals in black did not develop any injury because the ratio of tidal volume over end expiratory lung volume was low, but animals with high ratio developed injury in white, as shown by an increased lung weight caused by edema. And more or less in the same period as Gattinoni's group was performing this study, we were doing a study with positron emission tomography, where we used 2 CT scans at end expiration and inspiration, and a PET scan to assess the inflammation, the metabolic activity, or if you will, the inflammation of the baby lung. So basically, we were able to calculate the tidal volume distending the normally aerated tissue and the end expiratory lung volume distending, that was the size of the baby lung. And indeed, there are different normalizations, so don't worry, but the message of these slides tells you that the higher the ratio of tidal volume to end expiratory lung volume, the greatest is the amount of the inflammation. So really, we should care for scaling tidal volume over end expiratory lung volume. And maybe you might be thinking that I'm giving the wrong talk, but it's not the wrong talk. Because it's hard to measure end expiratory lung volume at the bedside. There's just one commercial ventilator that does that, and I hope in the future this measurement will be more and more available. But we can use a trick in ARDS. What is the trick? The trick is that compliance of the respiratory system is highly correlated to the volume of the respiratory system. So, as I told you, the smaller the baby lung, the more stiff it is. We can use compliance as a surrogate for end expiratory lung volume. So we substitute end expiratory lung volume with compliance. But compliance, it is the driving pressure, plateau minus PEEP, tidal volume divided by driving pressure. Tidal volume goes away with tidal volume, and basically we are left with the fact that driving pressure is proportional to the ratio of tidal volume to end expiratory lung volume. So again, tidal volume is replaced by compliance. We write the formula of compliance and we are just left with driving pressure. This is the reason why I think more and more evidence is showing that driving pressure is a powerful predictor, or a powerful, I probably should say, mediator of lung injury and death. Because driving pressure is just a simple way to express the concept of tidal volume over end expiratory lung volume. So this was a little bit of the background, just to understand why we are using a given number. It's not a magic number, it's a very rational number. So how do we measure driving pressure? I am sorry if I say something that it's obvious to most of you, but sometimes I had surprises. So apologies if this is too simplistic. So driving pressure is just plateau pressure during inspiratory hold minus PEEP. Okay, that is your driving pressure. Measure PEEP, measure plateau pressure, the difference is the driving pressure. If you are on volume control. If you are on pressure control, it's exactly the same. Just keep in mind that also in pressure control, you have to push the inspiratory hold button. Sometimes we are led to think that because pressure control is flat, that is a plateau pressure. Plateau pressure has two conditions to be a real plateau pressure. One, it is flat. Two, it is without any flow. So in the bottom of the right panel, you see that we measure plateau pressure when the flow is zero. And indeed, for the same tidal volume in the same patients, driving pressure is exactly the same no matter whether you use pressure control or volume control, just as a method aspect. So this is how to measure it. That's the other strong point about driving pressure. It's very simple. And the boom of the driving pressure came from this study by Marcelo Amato, who stubbornly has made this study appear in the New England Journal of Medicine. The study was rejected in New England, but Marcelo, he's a very stubborn person, knew that the science in it was very good, so he went through a hell of statistical work, and eventually the paper was accepted. And I think he deserves a great merit for this. You've seen this picture already, but basically what tells you is that this is a retrospective analysis of ARDS network studies, and as you see in the panel in the middle, you can increase, those are different quintiles of plateau pressure. Your plateau pressure can increase, but as long as the driving pressure in light gray is the same, there is no mortality change, as you see in the bottom. But look at the panel in the left. If the increase in plateau pressure is caused not by an increase in PEEP, by an increase in driving pressure, then you have an increased mortality. And vice versa. You can have this on the right, you can have the same driving pressure, plateau pressure, but if driving pressure decreases, then mortality drops. So really, there's not much to add to this plot, because it clearly shows that what matters is, I wouldn't say more than plateau pressure, but along with plateau pressure, driving pressure really matters. And this is also another very famous plot that somehow was used to find the threshold at 14 centimeters of water of driving pressure that separates patients in those at greater or lower risk of death. You are probably aware of the results of the lung-safe studies we published in JAMA last year. And I would say with some surprise, we found that there was an association between driving pressure and probability of death, which was, if you will, even more convincing than the one between plateau pressure and death. Why do I say we found this with some surprise? Because the study by Yamato was done on a cohort of patients which was carefully collected, randomized under controlled condition, so in a totally different setting, totally different patients, totally different design. Here we were looking at worldwide, we found the same results. So it probably means that there is some truth into this, and we also found a nice separation between survival and death, between patients with a driving pressure higher or lower than 14 centimeters of water. The second condition, the higher driving pressure being associated with a greater risk of death. We also have published this secondary analysis of the lung-safe study. I hope the table will not scare you. We looked at the different factors that were associated with mortality. Some were the usual known, and I am glad these are there, because again it means that the data is somehow robust. If I wouldn't find age as a predictor of death, I would be very suspicious. So we had age, neoplasm, the usual known, and we had some factors associated with ventilation, like a lower PEEP and a high peak inspiratory pressure are associated with a greater risk of death. We don't have driving pressure here for the simple reason that not in all patients we had this measurement. Plateau pressure, unfortunately, is measured only in about 40% of patients. So to have the largest cohort, we looked at peak inspiratory pressure. But if you think about it, lower PEEP and high PIP means a higher driving pressure. And indeed, we found that a driving pressure higher than 14 centimeters of water was associated with an increased risk of death of almost 20%. 20% in absolute increased risk of death in moderate and especially severe ARDS. So this means that if your driving pressure is above 14 centimeters of water, if a patient, his likelihood to die is almost twice, is 2/3 higher than if a patient has a driving pressure lower than 14 centimeters of water. Of course, these are observational data, so there's not necessarily a cause-effect mechanism, but for sure the association is pretty strong. So how do we use this in the clinical practice? And I'm going to finish. First, as I said, it's a marker of severity. We measure it because it tells us something about the severity of the disease, and then this is something that we do. We tend to think in terms of compliance, but you can think in terms of driving pressure. Say you are on volume control ventilation, you increase your PEEP, and so you basically go from a PEEP of 5 to 10, and if the lung recruits, you will see that plateau pressure increases only by 4 centimeters of water. So 5 in PEEP, 4 in plateau pressure. What does this mean? That driving pressure is decreasing, and indeed compliance goes up. What we would do in this case is go for this way. And again, you can decide to put recruitment maneuver in between, go with PEEP upwards or downwards, but the concept is the same. If by changing PEEP, your driving pressure decreases. This means that you are recruiting the lung. So you see PEEP 15, further recruitment, further decrease in driving pressure, further increase in compliance. But if we now exceed with our PEEP, because, oh yeah, I like it, driving pressure is going down, let's go up with PEEP. At some point we will bring the lung to over-distension. And this means that driving pressure will start rising again. So in Latin they would say hic sunt leones. This is where you should stop. You shouldn't let your driving pressure raise again because you are over-distending the lung. And I think yesterday Carlos Ferrer showed a beautiful approach to PEEP titration based on the best compliance. And so this is another case of a patient, and I'm concluding, I'm finishing, of a patient who cannot be recruited. We increase PEEP by 4 centimeters of water. We just distend the alveoli that are already open. So driving pressure stays at 26. Compliance does not change. And immediately we start to over-distend the lung. So this is a simple approach. It's if you want to call it a compliance or highest compliance, lowest driving pressure, it's the same if you are on volume control. Clearly, if you are on pressure control, your driving pressure will not change. What will change is the tidal volume, okay? So just keep in mind that if you are on pressure control, your independent variable is driving pressure, that will stay the same, and your dependent variable is tidal volume. So in conclusion, I think we really should look at respiratory mechanics when we are setting our tidal volume, our PEEP level. I think that we should not forget about plateau pressure. We must measure it if we, especially if we want to measure driving pressure. When we measure driving pressure, try to keep it below 14 centimeters of water and plateau pressure below 28. And my suggestion, I rarely say always or never, but in this case I think we can say to always check driving pressure after the application of a therapeutic maneuver, recruitment maneuver, bronchodilator, diuretics, anything we do, I think driving pressure, especially changing PEEP, I think driving pressure is a good indicator of how we are treating the lungs of our patients. I thank you very, very much for your attention. Sorry for being a few minutes late.
Thank you very much.